Hello again, everybody. Let's now come to the clinical presentation of the hypertensive patient. When the patient comes to see the doctor, what does the doctor look out for in terms of the history, the symptoms to ask about, and the examination? What are the signs the doctor needs to look for when examining the patient? So, it is important to remember that the hypertensive patient is often asymptomatic. Study after study has shown that the incidence of headache, palpitation, neck discomfort, any symptom that a patient complains of is actually the same in numbers amongst the hypertensive and non-hypertensive population. So hypertension cannot be felt by the patient. If the patient complains of a particular problem, it is actually an underlying condition that gives rise to his complaint and that also can cause the elevation of blood pressure. But it's not the elevation of blood pressure itself that actually results in the discomfort, unless, of course, there is severe elevation with organ damage and with clinical disease. Now, hypertension is picked up because of an abnormal elevated measured blood pressure level. And in assessing the patient, it is important to think of two things. One, what is the cause of the elevation of blood pressure? And the second is what are the results and complications of the elevation of blood pressure? Looking for organ damage, looking for clinical disease. Let's start with the measurement of blood pressure. Before measuring the blood pressure, the patient should be sitting quietly with the back supported for 5 minutes, resting. When measurement is done, the arm should be supported, that is rested, and at the same level as the heart. It is important not just to check the blood pressure in one sitting position or lying position, but to check for postural change. So get the patient standing up after lying down or standing up after sitting to take recordings immediately the patient stands or after 2 minutes to look for postural change of blood pressure, usually to pick up postural hypotension where the blood pressure drops when the patient stands up. Now, the patient should not have taken any coffee or tea in the preceding hour because that can raise the blood pressure level. The patient should not be smoking for the preceding 15 minutes. The patient should not be taking any stimulating adrenergic things, such as a Red Bull drink, for example, and the environment where the blood pressure is measured should be quiet and comfortable. In measuring the blood pressure, inflate the pressure cuff quickly and inflate it to 20 millimeters above the systolic level. How do you know that the systolic level is reached? Because that is the level when the radial pulse disappears. Feel the radial pulse inflate the blood pressure cuff quickly, and when the radial pulse is no longer felt, then you inflate it for a further 20 millimeters, and that is when you can stop. And as you deflate the cuff, you must deflate it very slowly. Deflating at 3 millimeters per second is very slow deflation. So in contrast to the inflation, which is quick, the deflation should be very slow. When you measure the blood pressure, you look for the disappearance of the coracle sounds. The time of disappearance of the sound is sorry, let me repeat that. You measure the blood pressure, you look for the appearance of the coracle sounds. The time of appearance of the sound is the systolic blood pressure. That's when you first start hearing the sound. That's the systolic blood pressure. And as you deflate it, you will constantly hear the sound. And the point of disappearance of the sound is the diastolic blood pressure. The point of disappearance of the sound is said to be phase 5 of the coracle sound, and that is taken as the diastolic blood pressure. Now, sometimes the coracle sound does not disappear. going to very low levels, you can still hear the sound, then that being the case, you should take the phase, the time when the sound becomes muffled. The phase where the sound becomes muffled is said to be the phase 4 coracle sound. Sometimes when the sound goes down to very low levels, using the phase 4 muffling of the sound would be the appropriate one for the diastolic blood pressure. So where the sound appears is the systolic blood pressure, where the sound disappears or becomes muffled is the diastolic blood pressure. In certain patients, the sounds are very difficult to hear, very soft, and if that happens, then you should exercise the hand, whether raising and lowering it or opening and closing the hand, so that afterward the coral cord sounds can be more easily heard. Now, remember that hypertension is bad because it leads to adverse clinical cardiovascular or renal events, which we are trying to prevent. And so when we approach the patient with hypertension, we should assess the overall likelihood of getting these adverse outcomes, which means we have to look for other risk factors that can produce these bad clinical outcomes. We have to look for organ damage. Those with organ damage are more likely to get the adverse outcomes. We must look for diabetes, and we must look whether they already have the atherosclerotic and renal disease. Because if they already have the disease, then they are more likely to get the disease. So it's not just about measuring blood pressure, it's about looking for all these things, the risk factors, the organ damage, the presence of diabetes, and the presence of disease. So when you question the patient, when you examine the patient, these are important. For the risk factors, age is an important risk factor. So you must know how old the patient is. Smoking is a risk factor that can lead to disease, so you want to know whether it is present. What are the lipids like? Are they abnormal? And if there's hyperlipidemia, it can be shown up, for example, by xanthelasma on the eyes or tendon at the hands and feet, whether the patient is obese, and whether the patient has a family history of heart disease or previous hypertension or stroke. All these are important risk factors to ask about in the history and to seek in the examination. Similarly with diabetes, is there a history of diabetes? Is there a family history of diabetes? And are there signs that you can pick up from diabetes that the patient may have? In terms of target organ damage, you are looking for left ventricular hypertrophy. This can be found with a strong, forceful, displaced apex beat. If the apex beat is forceful, then it is an indicator that the heart muscle could have been thickened. You feel the peripheral pulses, dorsalis pedis and posterior tibial at the feet. You feel the radial pulses at the hand to see if they are lost. Because if the peripheral pulses are lost, it suggests peripheral arterial disease. And you look for whether there is evidence for a previous stroke. You ask about a previous transient ischemic attack. You ask about angina. You ask about myocardial infarction. And you look for evidence of previous revascularization from the history or from a chest sternotomy scar in the patient. You look for evidence of heart failure, elevated jugular venous pressure, perhaps pedal edema, perhaps a story of inability to lie down or topnia, or breathlessness in the middle of the night, PND. You look for evidence of renal failure. Is the patient sallow? Is the patient pale? You ask about whether there have been evidence of previous any abnormality that the patient has been told about, or whether there is edema of the lower limbs, because perhaps the patient is having a proteinuria. Again, in peripheral arterial disease, the patient may complain of pain in the legs on walking. There will be perhaps arterial ulcers in the lower limbs with absent pulsation of the pulses. You have to look at the fundus to look for hypertensive changes and perhaps for changes of diabetes. Now, certain important signs should be remembered because they're very easy to pick up, and unless they're picked up on examination, they can be easily missed. Look for radial femoral lag, that is, feel the radial pulse, feel the femoral pulse, and they should be felt together. If they are not felt together, then perhaps there is coarctation of the aorta, resulting in a slower, weaker femoral pulse compared to the radial pulse. Look at the fundus for retinopathy of hypertensive changes, auscultate the abdomen and the loins for the renal bruit, because renal artery stenosis can be picked up with the renal bruit, and if the doctor is not attentive to look for it, it is a condition that can be missed for years, and the patient's hypertension will be difficult to control. So look for renal artery stenosis by auscultating for the bruit. And finally, remember the peripheral circulation. It is an indicator of whether the patient has other organ damage, because if the peripheral circulation is compromised, then the cardiac system, the neurological system would perhaps also have circulatory abnormalities. If the peripheral circulation is compromised, perhaps the patient has diabetes. Now, in evaluating hypertensive patients, we have to remember the causes of secondary hypertension. And these are the causes that have been mentioned previously, that drug, renal disease, renal artery stenosis, coarctation, pheochromocytoma, Conn's, Cushing's, hyper and hypothyroidism. All of them can cause secondary hypertension. So, in investigating the patient or evaluating the patient, you must think about and examine these conditions in mind. Ask whether the patient is on any medication. Remember, examine for renal artery stenosis, coarctation of the aorta. Ask about whether the patient has episodes of palpitation, headache, flushing, which may indicate pheochromocytoma. Ask about whether the patient might be weak, because Conn's syndrome would cause hypokalemia, and hypokalemia can result in weakness. Does the patient take painkillers? Because some proprietary painkillers, some traditional medicine may contain steroids, which make them cushingoid. And look for evidence of hyperthyroidism in a thin patient with tachycardia, or hypothyroidism in an obese patient who is slow, with hoarse voice perhaps. So all these are important. History and examination of the patient, thinking about secondary hypertension and trying to pick it up. Now we come to tests to do for the patient with hypertension, and essentially it is very similar. Thinking about underlying causes of hypertension and trying to look for the complications of hypertension to prevent future adverse clinical disease. So in the blood test, we look at the hemoglobin, is the patient anemic, and the ESR. If it is elevated, then perhaps could the patient have some form of vasculitis that leads to vasoconstriction and elevated blood pressure, or vasculitis causing renal damage that can cause hypertension. The potassium is very important, because low potassium may be indicative of hyperaldosteronism, Conn's syndrome, renal artery stenosis, or Cushing's syndrome. All of them would have hypokalemia. Hyperthyroidism can also be associated with hypokalemia. Renal function is important, because kidney dysfunction can cause hypertension, while at the same time, long-term hypertension can result in renal dysfunction. In the urinalysis, examine the urine to look for protein, and before there is clear protein in the urine, there is what we call microproteinuria, when the level is 30 to 300 milligrams per 24 hours. Chest X-ray is important, looking for the heart size. If there is cardiomegaly in hypertension, it is common because of the left ventricular hypertrophy. Is there heart failure? Because if the heart pumps against a higher blood pressure level, a higher resistance over the long term, it can weaken and fail. And is there rib notching? Now, rib notching comes about with coarctation of the aorta, because if the blood cannot flow along the normal aorta, it then bypasses the obstructed part of the aorta flowing through the rib, and then you will have erosion of the ribs, producing rib notching. The ECG is important, looking for thickening of the left ventricle hypertrophy, looking for a heart attack, or the ST depression of ischemia, both of which can be due to underlying hypertension. Ultrasound of the kidneys is another useful test to do. Now, again, remember the secondary causes of hypertension, and in further investigation, we try to look for them. For example, the 24-hour urine metanephrine or catecholamine would pick up pheochromocytoma. The thyroid function test is important, looking for hyper or hypothyroidism. That means the TSH, free T3, free T4 will work out the thyroid status, as would assessment of serum cortisol for the diagnosis of Cushing syndrome. Growth hormone assay, for example, may be important in a patient who may be having acromegalic features. And finally, the renin, angiotensin, aldosterone levels may have to be assessed in a patient with hypokalemia for whom Cushing syndrome is suspected. Now, a CT scan of the appropriate section for the arch of the for the aorta, perhaps, or for the renal circulation, a CT angiogram will pick up specific conditions like renal artery stenosis, as would an MRI or MR angiography for these particular diseases. Now we come to the treatment of hypertension, and the principles of the treatment are fairly simple. We want to try to reach optimal blood pressure levels, which, as you will recall, should be a blood pressure below 130 by 80 or below 140 by 90 in the older population group. We should treat all risk factors in addition to the control of the blood pressure. We will use combination drugs to reach the blood pressure level. Remember that the aim is to protect the organ system that is at risk. So if there's evidence of damage for a particular organ system, then the drug chosen should be that which best protects that system. We have to remember that there is no magic bullet. Every drug has its advantages and specific disadvantages. And finally, while we reach optimal blood pressure control, we must remember, because of the disadvantages of the drugs, we do not want to seek too low blood pressure levels, and we should not try to normalize the blood pressure level to below 120 by 80. Reaching below 140 by 80 or 130 by 80 should be adequate. Lifestyle measures must not be forgotten. It is important to know that primary hypertension is often a lifestyle disease, and with weight loss, blood pressure can come down. With alcohol restriction, blood pressure can come down, as can salt restriction lower blood pressure. Potassium intake is often inadequate in the hypertensive patient, and if fruit intake is increased, potassium intake is increased, blood pressure levels can come down. Similarly, activity and exercise will lower blood pressure, and of course, stress and anxiety and worry are all very bad for hypertension. As for the drugs, you can remember it by remembering ABCD, the angiotensin converting enzyme inhibitors, and the ARBs, the beta blockers, the calcium blockers, and the diuretics. And finally, other drugs such as the alpha blockers are available. Now, what about the renin-angiotensin antagonists that are available? These drugs, the ACE inhibitors and the ARBs, are especially good in protecting the kidney. So they will prevent renal impairment, they will slow down renal impairment, and they are especially useful in the patient with proteinuria or microproteinuria. They are also useful in patients with heart failure. Those with systolic heart failure will do well with the heart failure and hypertension when used, when put on ACE inhibitors, ARBs. Now, they all have an insulin sensitizing effect, which means that they can improve diabetic control. They make the insulin function better. And there's some evidence that they are especially useful in patients with stroke and left ventricular hypertrophy. They have their disadvantages, the main one being that if you put a patient on these inhibitors, if they happen to be Asian, there is a 30 to 40% chance that they may cough. So cough, although it is a benign condition and does not indicate respiratory damage, would be an irritating symptom, and perhaps it is reasonable to warn them if they are started on ACE inhibitors. Although ACE inhibitors and ARBs are good in protecting the kidney, when you initially start them, the creatinine level rises, and if the patient is dehydrated, you can actually precipitate renal failure in these patients. In the patient with renal artery stenosis, they might be dependent on renal perfusion from the activated renin-angiotensin system. And so if you start patients on these drugs, you can actually initiate renal failure, which is not a good thing to do. So remember that although they are renal protective, in dehydrated patients or those with renal artery stenosis, they can actually cause renal failure. What about beta blockers? Well, these agents are very good for ischemic heart disease. They are the treatment for angina and in patients after myocardial infarction. Three of them, bisoprolol, carvedilol, and metoprolol, are especially good in patients with systolic heart failure. In any patient with excessive sympathetic drive, like in thyrotoxicosis, in the younger patient, in the anxious patient with tachycardia, beta blockers are very good. However, beta blockers have an adverse effect on the quality of life. Patients feel tired and slow, perhaps some complain of impairment to the sex life. So they have an effect on the quality of life which patients may not like. Similarly, in the patient with obstructive airway disease, then beta blockers can precipitate bronchospasm, which is not a good thing to do. And finally, beta blockers actually increase sugar and lipid levels, which is not good because both of these are risk factors for the development of cardiovascular disease. What about calcium blockers? Well, calcium blockers can be considered in three groups. The dihydropyridines are vasodilators. Verapamil is like a beta blocker. It slows down the heart rate, it slows down the force of the heart. So, on the other hand, the dihydropyridines, by being vasodilators, cause a tachycardia. They reduce the strain on the heart. So, at different ends of the spectrum, calcium blockers function very differently. Vasodilatory, dihydropyridines, and beta blocker like verapamil. In the middle is still Thiazide. So there is a spectrum of three types of drug function for calcium blockers. Now, all calcium blockers are relatively potent agents for controlling blood pressure, particularly the dihydropyridines. They are all useful in patients with ischemic heart disease, and they are said to be especially good in the elderly patient if they have isolated systolic hypertension. They are also very good for stroke prevention and have been shown perhaps to have a special good effect in this area. However, there are disadvantages. Now, the vasodilatory dihydropyridine can produce pedal edema and flushing of the face because by vasodilating, they will cause edema fluid to leak out into the lower limbs, and by vasodilatation of the face, they can cause flushing and tachycardia. Verapamil, on the other hand, is like a beta blocker, slowing down the heart rate, reducing the force of the contraction. And since it functions like a beta blocker, you should not combine verapamil with a beta blocker because there might be excessive slowing of the heart rate and precipitation of heart failure if you reduce the force of contraction too much. Finally, the short-acting nifedipine, which is a vasodilatory dihydropyridine, should not be used. In fact, all short-acting antihypertensive drugs should not be used because you will not be able to cover a 24-hour period for the patient. If you are unable to have the drug cover the 24-hour period, there is some evidence to show that the rebound in blood pressure is bad for the patient and in fact increases the chances of a myocardial infarction. What about diuretics? Well, the way it works is very simple because if there is excessive volume in the circulatory system with fluid retention, then blood pressure goes up. If you use diuretics, you cause the patient to pass more urine, you deplete the intravascular volume, and so you will lower the blood pressure. So diuretics are very potent agents, and they are especially useful in older patients with isolated systolic hypertension. Now, the all-head study was run with the aim to find out which group of hypertensive drug would be best. Would it be the diuretic? Would it be the calcium blocker? Would it be the ACE inhibitor? Or would it be the alpha blocker? The diuretic is the oldest drug amongst these groups, and the feeling would have been that one of the newer drugs would be found to be better than the diuretic. To the surprise of the organizers of the trial, and this is a huge trial involving tens of thousands of patients, at the end of the 5-year trial, it is the diuretic that was best for the patient, reducing heart failure, reducing stroke more than the newer agents. So the surprise is that an old drug, a potent drug, actually works as well as, if not better than, the newer one. The diuretics are said to be especially good in stroke prevention and in the prevention of heart failure. There are a lot of disadvantages with the diuretics, and it is because of these disadvantages that newer drugs are sought and felt to be better. That diuretics increase sugar, lipid, and uric acid levels. That diuretics can cause electrolyte imbalance, lowering the sodium, and for the thiazides, lowering the potassium too. For the potassium sparing spironolactone and amyloride, but they can lower the sodium and elevate the potassium level. So diuretics can cause electrolyte imbalance, and if a patient is dehydrated, such as losing appetite perhaps, or having diarrhea. When the patient is dehydrated and you further deplete the volume with a diuretic, then you can actually cause hypotension, renal failure, and bad things for the patient. So diuretics do have their side effects, but remember they are actually very potent, very good drugs, and used safely would very well protect patients from the organ damage and clinical disease that hypertension brings about. Finally, the alpha blockers are useful in prostatism. They are vasodilators that also work to reduce the size of the prostate. And for elderly patients with prostatism and hypertension, alpha blockers may be best. The disadvantage of alpha blockers would be postural hypotension, especially with its first dose. If a patient is put on an alpha blocker, you have to warn them not to get up fast, especially when they have just started taking the medicine, because the blood pressure can drop with their getting up fast and they may fall down and hurt themselves. Most alpha blockers now are single dose long acting agents except prazosin. And again, a short-acting prazosin produces tolerance, such that you have to constantly increase the dose to get the same effect for the patient. So avoid short-acting drugs, and for alpha blockers, beware of postural hypotension. So these are some terms and things that would be good for us to talk about. Isolated systolic hypertension is when the patient only has an elevation of the systolic blood pressure. The diastolic blood pressure is normal. This is a fairly common condition in the elderly group of patients. It has been found to be clearly as bad as hypertension of the diastole and systole. If a patient has isolated systolic hypertension, they must be treated. Systolic blood pressure should be brought down below 130 or 140, depending on the patient. And we do not worry that the diastolic level is already low. Using treatment for these patients will not lower the diastolic further, causing harm to the patient. So isolated systolic hypertension must be treated as normal hypertension. White coat hypertension or labile hypertension is when a patient has an excessive elevation of blood pressure depending on circumstances. When the patient comes to the clinic, when the patient is anxious, faces stressful conditions, then blood pressure rises significantly. If the patient is at rest and calm, the blood pressure is actually quite normal. Such patients do not do as badly as patients with full-time hypertension. However, patients with white coat hypertension also have higher strokes when compared to those with normal blood pressure levels. So if you see a patient with white coat hypertension, the condition should be explained to them. Treatment should be with them trying to change their attitude and lifestyle. But at the same time, if that person controls the blood pressure, then drug therapy would be required to prevent the development of future stroke. Hypertensive emergencies come about when the blood pressure rises very high. Now, if the blood pressure rises very high, and this very high blood pressure damages the organ system, producing heart attack, producing acute pulmonary edema, aortic dissection, or papillary edema, then this is an emergency that has to be handled with admission and intravenous drugs to bring the blood pressure down over a matter of hours. Otherwise, the patient can die. It is the elevation that causes severe immediate organ damage. That is malignant hypertension. That is a hypertensive emergency. On the other hand, the ordinary hypertensive patient can sometimes have the blood pressure go up, maybe as high as 250 by 130. Again, the patient remains generally asymptomatic with no acute impact from the marked elevation of blood pressure. Whatever damage there is due to the long-term underlying elevation of blood pressure, not due to this immediate high blood pressure level. That condition is called a hypertensive urgency, where it should be brought down, but over a matter of days. So it's important to distinguish an emergency where there is immediate organ system damage and disease produced by the blood pressure versus an urgency where the patient has chronic damage and only elevation blood pressure he does not feel. So one has to distinguish the two because the emergency is treated intravenously with admission. The urgency is treated with oral medication over a period of days. Finally, home blood pressure recordings are now increasingly being used as our 24-hour ambulatory recordings. And while any elevation of blood pressure is bad, the exact definition and normality of these readings at home and the ambulatory record is still a matter of development. So if a patient takes the blood pressure at home, they should be encouraged and allowed to do so, and the doctor has a look at the recording. Having a look at the 24-hour recording or the home recordings will give an idea of how the patient is functioning, but the patient and the doctor should not react to any individual reading, such as if the blood pressure is low, to stop medicine, or if it is high, to add medicine. That's not the way to manage a hypertensive patient. Hypertension is a long-term condition giving rise to long-term disease. So the immediate rise and fall of blood pressure is not so important. Remember, do not react to a blood pressure reading, but always focus on the prevention of damage and clinical events for the patient in future. Finally, hypertension is a topic on which I have written in Journal of American Medical Association a letter, in the Lancet another letter, in medical journals of New Zealand, in the British Medical Journal, in the Singapore Medical Journal, and the Malaysian Medical Journal. So it is a topic for which I have particular interest, and it is not as simple as what people feel it is. Blood pressure monitors are available everywhere for everybody, but hypertension is not about blood pressure recording. It is about protecting the patient's future, reversing damage, and preventing ill health that can occur in the future. And with this, I shall stop here. Thank you.